We admit to ICUs more and more immunocompromised patients. There is a growing number of solid organ and bone marrow transplant recipients, but we have also patients with hematological, oncological patients with both solid tumors and hematologic malignancies. We have patients with autoimmune diseases, with other diseases which can cause immunosuppression or require immunosuppressive therapy, and patients with immune deficiencies. And the group 2 and group 3 can be not diagnosed before ICU admission or before ECMO initiation. So we should know these diseases. Of course, the main problem are infections, but with opportunistic infections, we have more problems because they are rare in general population. They are not routinely searched. They are difficult to diagnose and difficult to treat. And for example, cytomegalovirus infections, usually we have only the blood tests available, but not tests for pneumonia. And of course, immunocompromised patients more frequently, if they infected, they develop ARDS and septic shock. And if we try to answer the question whether we should use ECMO in immunocompromised patients, historically, the immunosuppression was contraindication. But now, in guidelines, European Extracorporeal Life Support Organization lists immunosuppression among relative contraindication. But in fact, what is absolute contraindication to ECMO? It's only the only absolute contraindication is anticipated non-recovery without a plan for viable decannulation. What does it mean? In fact, this is a three-step approach. First, ECMO may be the bridge to recovery. So, is the pulmonary pathology reversible? If no, ECMO may be bridge to transplant. So is the patient, or would be the patient, a candidate for transplant? And answer may be yes, no, or I don't know. So if no, it's not, ECMO should not be used. If I don't know, the ECMO may be a bridge to decision. We may use predictive scores, but we have predictive scores only for venous ECMO. And the first of this score, PRESERVE score, was developed using 140 patients cohort in France. Many of them were immunocompromised, and the highest odds ratio was for immunosuppression. But when the categorical continuous variables were categorized and beta coefficients rounded to the nearest integer, we have the score. And in this score, 2 points for immunosuppression, and for the men, unfortunately, I am so old, more than 55, 3. So I am very unhappy. Okay, but maybe we should not refuse ECMO in immunocompromised patients. Another score, they assessed survival. So here the odds ratio less than 1 show that this is a risk factor for mortality. Okay, when it was translated into points, immunocompromised patients performs much better than patient with central nervous system dysfunction, better than patient with age more than 60 years. Okay, so maybe do we have any scoring system for VA ECMO? No. And in fact, it was even proven that they don't work in immunocompromised patients. The SAFE and other did not include immunocompromised status. And interestingly, one developed using artificial intelligence, so did not show immunocompromised status as a risk factors. Okay, so let's look at the literature, and they are mixed reports. They are reports on mixed population and or specific population of immunocompromised patients, so mixed population. very valuable report, again from France, 203 patients. So ECMO was weaned in 42% of patients. 34% of patients survived the discharge, and 30% survived 6 months. You see those differences, yeah? And of course, there was one very interesting observation, that if the immunosuppression, immunocompromise, was diagnosed in the period which was shorter than 30 days before ECMO, these patients with, let's say, short-lasting immunocompromised status performed better. And who also performed better? People who received immunosuppressive drugs. How this compares to general ARDS population? There was a sub-study using a LungSafe database, and hospital mortality was higher in immunocompromised than immunocompetent patients, but it was 52%. So maybe it's not so different from mortality on ECMO, yeah? And other patient series from other countries, in fact, more or less confirmed what French people noticed. So here you can see in Freiburg, the cohort, 27% survival to hospital discharge. Again, this so-called ECMO gap. So the rate of successful weaning is higher than the rate of survival, especially in some groups. The same story more or less in Korea cohort, in Chinese cohort, and in another Chinese cohort, a very interesting observation that people who were put on ECMO being on non-invasive ventilation performed better, even if then they were later intubated, than people intubated from the very beginning. One report differs from the others. American report of mixed population, of course, respiratory ECMO VV more frequently used immunosuppressed patients than VA, but no difference in outcomes between immunosuppressed and non-immunosuppressed patients. And for VA, we have just one report, so you can see VA ECMO in immunocompromised patients, 90-day mortality 70%, 1-year mortality 75%, very, very high. And solid organ transplant recipients have the worst performance. Okay, so maybe we should look into specific populations. The specific etiologies of immunocompromised status. So that's our case. Recipient of kidney, polycystic kidney disease was the reason that finally end-stage renal disease developed, 55 years old, but he was in fact troubled by complications of immunosuppression after her transplant. Pneumocystis urologicis, cytomegalovirus, and finally pneumocystis aeruginosa, causing severe pneumonia, ECMO initiated, and with some troubles, but we were able to wean her from VV ECMO. We were really very happy. She was alert, cooperative. We were able even to wean her from ventilation. But what happened? Again, septic shock, perforation of signum diverticulum, and she died. Another lady, COVID-19 in 2025. Young lady, Alport syndrome, yeah? But she was primarily in other hospital, refusing intubation. Intubated very, very late. So the same day, intubation and ECMO, stiff lungs, no improvement, complications only, she died. And another man, cardiovascular comorbidities, again, both pneumocystis and cytomegalovirus, and it was really a disaster. She also died. What's in literature? Surprisingly, very little information. So one series 33% of patients survived 6 months. Small series. Another series from China. In fact, this was in people with kidney transplant and pneumocystis jirovecii. And people on ECMO performed better than people which were not treated with ECMO. But small numbers. There are some data on liver transplant. So ECMO is used as a bridge to liver transplant, as an intraoperative salvage via ECMO, or in postoperative phase in case of pulmonary complications, more or less 50% survival. ECMO is, of course, used in case of acute graft lung rejection. This is a bridge to retransplantation and is used also for graft dysfunction early after heart transplant via ECMO. Okay, what about hematopoietic stem cells transplantation? Very poor performance, poorer than in other oncological subpopulations. Okay, and what about cancer? That's the series of oncological patients, only 27% survival. And propensity score matching with the population from other studies, also cancer patient, suggested no survival benefit of ECMO. So maybe autoimmune diseases. This is our second case. A young boy, in fact, who was primarily diagnosed of ulcerative colitis, then 2 episodes of DVT, and during the second episode, massive hemoptysis and perforation of the bowel. And doctors from other hospitals were really, really smart because they thought, okay, let's perform autoimmune panel. Very high antibodies against proteinase 3 suggested the diagnosis of ANCA-associated vasculitis. We used ECMO in this man. We finally were able to withdraw ECMO and to wean him off ECMO and off mechanical ventilation. But we simultaneously had to give him rituximab and fight with infections. And then we transferred him to another hospital, and I don't know his further follow-up. Series from ELSA registry, survival, 73%. So let's use the ECMO in this subpopulation of patients. SLE, that's quite tragic case from our experience, very, very quickly developing new lung respiratory failure and cardiac failure with cardiac arrest. So it was VA ECMO immediately reconfigured to VAV ECMO, and it was also defeat. And finally, maybe immunodeficiencies. AIDS. Survival to discharge from ECMO ELSA registry, 36%. And I think it's more relevant than the next report. But such reports are published because this is a systematic review of case report of case series. I am not surprised that here survival is 93%. Publication bias is huge. So just beware of such reports because I think they are invalid. If we look on ECMO and pneumocystis jirovecii, another series of patients with HIV performed better than patients without HIV. Surprise. And in another series, awake ECMO performed better than non-awake ECMO. And finally, primary immunodeficiencies. I think we had a very interesting patients. 35 years old woman with severe respiratory failure due to respiratory syncytial virus. So we thought, this is not this age group. What's going on? Let's measure immunoglobulins. And we detected severe deficiency. So it is, in fact, common variable immunodeficit. So we supplemented the immunoglobulins. We were able to wean off her from ECMO, temporarily weaned off her of ventilation, but she was troubled, and we were troubled by recurrent various infections, which unfortunately finally killed her. And what are the data? Only for people under 18 years, only for children and young people, not under 18 years of age. Survival to hospital discharge in primary immunodeficiencies, 45%. So, concluding, I must agree with the review published some years ago that still thinking about ECMO in immunosuppressed patients is like drawing a line in the sand. And to make long story short, we need individualized approach to consider the cause and duration of patient immune impairment, coexisting infections and comorbidities, and how these patients responded to the therapy of their disease which cause immunocompromised status. Thank you very much.